This is really about taking care of people's health and well-being. And the best way to do that is a stable home, a door you can lock, a bathroom of your own, a kitchen to cook in, a stable place to be where you can be safe and secure and connected. So I think we have to address it in the same way that we would address a pandemic or any other public health crisis.
Welcome to The Other 80. I'm Claudia Williams. This episode is the last of season 2. Thanks so much for listening and for your support of the podcast and me over the last season. After a brief break, we'll resume in early September with the first episode of season 3. Today, we'll be talking about homelessness, which starts with an understanding of the big changes in the availability of affordable housing over the last 50 years. Believe it or not, in the 1970s, America had a surplus of affordable housing. So much so that in 1973, Richard Nixon put a moratorium on the construction of new housing by major HUD programs. Now, in the U.S., we are millions short in affordable housing units. Jeff Olivet joins us today to talk about this issue. He is the executive director of the United States Interagency Council on Homelessness, and he's worked to prevent and end homelessness across the U.S. for more than 25 years. He says that while the problem is complex, the math isn't. We need to build more affordable housing, and quickly. So please welcome Jeff Olivet to The Other 80. A quick note here. This conversation was recorded about 3 weeks before the recent decision from the Supreme Court that criminalizes the act of sleeping in public places. We will talk more about the ramifications of that decision at the end of the episode. Well, Jeff, it's just wonderful to have you on the show, and the topic of housing and its relationship with health has come up quite a bit in our conversation. So we're really looking forward to digging in with you.
It's great to be here with you, Claudia. Thank you.
Well, just as a start, could you introduce yourself to our audience? What's important for us to know about you?
Currently, I'm in the role of executive director at the United States Interagency Council on Homelessness, and that's a federal agency dedicated to the work of preventing and ending homelessness in the United States. I guess the other thing I'd like your listeners to know is that I come out of direct service work. I was a street outreach worker, a case manager. I did a lot of local coalition building, as well as national advocacy, policy, and research work before joining the Biden-Harris administration.
You know, I live in the East Bay in California. There's a lot of talk about solutions, about strategies, about trends. I wonder if you could kick off by giving us all a sort of 101 on what trends are we seeing across the nation? How has that changed over time? And what are some of the most important drivers to think about when we think about homelessness?
Well, if you're living in the East Bay, you see this every day. We see unsheltered homelessness, people living under bridges and in encampments and in broken down RVs. We've seen homelessness increase over the last year and a half or so. And that was after some years of reductions from kind of the mid-2000s to the mid-2010s. We saw pretty steady reductions in homelessness. And then starting in about 2016, the numbers started increasing again. The pandemic did some strange things to homelessness. Like we saw a lot of people in real crisis, economic crisis, health crisis. And we also saw a huge investment of federal resources to keep people stabilized. We were able to invest through the American Rescue Plan billions of dollars to prevent evictions, to provide new housing vouchers, to address homelessness really head on. But now a lot of those pandemic era resources have expired, and we've not been able to get the support of Congress to fund all of the things that we want to do to continue some of those gains. So during the pandemic, we actually saw a flatlining of homelessness. We were able to kind of stave off a tsunami of homelessness. But then in the last year or so, we've begun to see it increase again. The concrete ask I would have right now is that in the president's budget for next year, we put forward guaranteed vouchers for every extremely low income veteran and every young person aging out of foster care. What that would do is show kind of a proof of concept for universal vouchers. It would say, if we can get people stably housed and provide support for them to be housed, we could essentially finish the work of ending veteran homelessness. We could make sure that no young person ever ages out of foster care into the streets or the shelters. So we've got a concrete budget ask on the table. We need congressional support for that.
On this podcast, we focus a lot on the move within healthcare and especially in Medicaid to bring together medical and social services. And one of the things that I'm starting to notice as I'm digging in more is that while we're expanding our perspective to what I think of as individual social services, so like, do I have meals? Do I have a housing voucher? I think we still have work to do to expand our thinking to the systems drivers. So what does the housing stock look like? What does the food system look like? And you've highlighted this same issue in the work to stop homelessness. In other words, we focus on the individual services that people might need in crisis, but don't focus as much on the systemic drivers that you've been talking about. Can you talk a little bit about what that looks like in your world? What does it look like to take a more systemic focus versus an individual risk focus?
Well, I think you said it very well, Claudia, that there's kind of a difference between root cause of homelessness and individual risk factors that put people at a higher risk of homelessness. And I'll just give you one example of this. In 1970, we had a surplus of affordable housing units in this country. It wasn't huge, but there was a surplus of about 300,000 units, more than people who needed them. Today, we have a deficit of more than 7 million units of affordable housing. What that says to me is, as we have disinvested in housing, as we have not developed housing supply on a scale to keep up with the need, many, many more people have slipped through the cracks and fallen into homelessness. The people who are most likely to become homeless are often people who are facing poverty and ongoing discrimination based on race and skin color and national identity and sexual orientation, gender identity, disability. It's people who have experienced trauma and domestic violence. 50 years ago, we still had domestic violence, we still had addiction, we still had mental illness, and we didn't have perfect systems to address that, but we had enough housing for everybody, and we did not see homelessness on the scale we see it today. So when we're responding to homelessness, it's critical to individualize support for people to make sure they have access to the care they need in terms of health and mental health and recovery and all of those important things. But if we don't solve the underlying structural stuff, the lack of affordable housing, the ongoing discrimination that people of color and LGBTQ people face in jobs and trying to buy a home or rent a home, in the criminal legal system, in education, if we don't solve that underlying stuff, we're going to keep seeing homelessness for a very long time to come.
Let's go back to the congressional ask, which is vouchers to make sure that every veteran and every person aging out of foster care services has access to housing. If we give someone a voucher, but there's no house available, that doesn't really solve the problem. So is there a complementary, either federal or local effort that's needed that would meet the voucher halfway by actually increasing the supply of affordable housing?
We're doing exactly that. The White House, a little over a year ago, released a housing supply action plan that takes a number of steps around financing and regulatory flexibility to try to get more apartments online, more rental units online. And that is really beginning to show progress. The administration's been able to help get the country back on track to produce more rental units over the next year than we have in decades. So we recognize the housing supply part of the equation, and then you've got to pair that with subsidies so that people actually can afford housing. If housing was affordable to all, maybe we don't need vouchers, but it's just not. It's out of reach for far too many people.
I was part of the Office of the National Coordinator for Health IT, and we had some direct work, at least when I was there, that was around incentives for doctors, hospitals, and others to adopt electronic health records and promote the exchange of information. And at the same time, we had this very crucial role, which we're now seeing reinforced in the world of AI, to coordinate across all of the parties in the federal government that have a hand in health IT. So the VA, the DoD, NIH, the FDA, it's a very long list of organizations. It's easy to write those words on paper. It's much harder to do that coordination work because every federal program has its own set of constituents, its own set of rules. You're now a couple years into this role. What have you learned about the job of coordinating in the federal government against your bold goal, which is to reduce homelessness 25% by 2025?
If we're going to really create a more person-centered approach to how we do our work, we've got to start with the person, not the funding stream. We've got to start with that family or that individual, and not the data system that they're sort of they happen to be in that moment. Our job is to coordinate across the federal agencies, and we've got 19 member agencies. Some good examples of that, if you look historically, are efforts like the HUD-VASH program. This is the Housing and Urban Development Department partnering with the Veterans Affairs system and really letting HUD do what it does and VA do what it does, which is HUD doing the housing, VA doing the wraparound healthcare, but creating this stable base of permanent, affordable housing for a veteran and a really good wraparound system of care. That's the way we do stuff. And that's our job at the federal level, is to try to help foster those kinds of partnerships. But I think there was something implied in your question, which is collaboration's hard and cross-system work is hard. And you kind of come up against systems that have developed over many years, many decades, and you're trying to sort of streamline and create speed and humanity out of that. And it's challenging, but I think we're making progress.
I watched some of the previous interviews you've done, and you used a term which I've used a lot in my work, which is positive deviance and bright spots. And while I think the national trends and the fact of any homelessness is very sobering and should be sobering for everybody, we do have cities and areas of the country that have really turned things around. And you've mentioned some of them in the previous conversations: Houston, DC, Chattanooga. Can you talk a little bit about some of those examples and bring to life what is it that they are doing and how are they doing it?
There are really steep hills to climb, and there are fierce headwinds right now. The cost of housing is tough in a lot of communities. There's not enough of it. Our direct service providers are spread very thin, particularly after the pandemic. And so I don't want to sugarcoat any of the challenges many communities face. At the same time, we're seeing some incredible bright spots around the country where places like Santa Clara, California, have been able to really focus on homelessness prevention and preventing people from having to go to homeless shelter, but instead provide flexible funding to help them stay put in their homes where they are. I was recently in Dallas, Texas, and there's some incredible work going on around veteran homelessness, where they've been able to see real decreases in veteran homelessness, but also unsheltered homelessness, addressing encampments in a very humane way where they're getting folks into housing, not just sweeping encampments and hoping the problem disappears. So I think there's a level of kind of creativity and collaboration that's happening in those areas that's really driving positive change, even in the face of some of the headwinds.
If you could distill a kernel of insight from one or two of those places that you'd love to see spread, understanding that each environment's different, but still there are some sort of scalable things going on, what would those be?
When communities are making progress on homelessness, one thing that's consistent is you've got everybody pointing the same direction, everybody rowing toward the same goal. And what I mean by that is it's often a very strong mayor or other elected officials at the city or county level who have a vision, who are bringing people together. We see involvement from the business community and the faith community. We see really good nonprofit organizations who are collaborating well. We see the philanthropic community supporting where government can't. We see a focus on shared outcomes where it's not just, trying to do good work, but it's actually about helping people exit homelessness. And that kind of everybody in it together is what seems to make a real difference. And I would add to that, that includes health systems. It includes big hospitals and outpatient clinics and federally qualified health centers and Healthcare for the Homeless projects, where the entire community is treating this like a public health crisis and coming at it just like we would a pandemic or a natural disaster with that same kind of urgency and collaboration.
I'm really struck by your mentioning mayors because I think this is an area of work where mayors are just extraordinarily important.
That's right. I mean, and at the federal level, what we try to do is provide as much funding as we can, some kind of broad policy directions, sharing evidence based practices and what's working. But the real work of ending homelessness happens at the local level. And mayors, I think, and I spend a lot of time talking with mayors around the country, they don't always have all the tools they need, but they are in a key position to mobilize people and resources and public will and public perception and really just kind of using their platform to drive hope, to drive confidence, to drive urgency. And we've seen a number of mayors do that very well, including Mayor Bass in Los Angeles, Mayor Johnston in Denver, where the force of a visionary mayor who's committed to sticking through on addressing homelessness begins to make a real difference.
In 2022, your agency released a strategic plan. It had 3 pillars focusing on prevention, crisis intervention, and then also housing and supports. And in particular, you've really placed an emphasis on prevention. And I think across many domains, prevention is the area that gets the least investment. A podcast was summarizing the seminal study that was done in San Francisco by UCSF on the drivers of homelessness in California. And one of the things they really highlighted was how much easier or how much more effective it is to intervene and help someone at that first signal that there might be emerging housing instability, often triggered by some other event in your life that makes it harder to balance your budget in that moment. I'm curious, as you think about that federal focus on prevention, what does that actually look like? What are the kinds of strategies that are effective? And how do you think about scaling those across the country?
Let me start tackling that by offering a parallel in healthcare. High blood pressure runs in my family. It can end badly, or you can intervene early and hopefully it doesn't end badly. But imagine if the only response to high blood pressure was we wait till somebody shows up at the emergency room having a heart attack, and that were our whole healthcare system. It's much easier to prevent the heart attack from happening in the first place. It's cheaper, it's more sustainable, it's certainly better for that person's health and lifespan and everything else. Yet around issues like homelessness, often we wait for the crisis to happen and then mobilize a response. So, in other words, over many decades, we've built up a pretty sophisticated emergency response to homelessness. We've got a very good emergency room in a lot of ways. It's not perfect, but we help people exit homelessness all the time. We've got very good outreach teams and street medicine teams. Absolutely, we need more places for people to be inside and safe. And it's imperfect, but that's been the primary focus for many years. Then I think we got better starting in the maybe late 90s, early 2000s, saying, wait a minute, we really need to focus on housing and supports to help people exit homelessness. And we've invested a lot in permanent supportive housing and rapid rehousing and a lot of other approaches that have been very effective in helping people get out of homelessness. And yet people keep becoming homeless every year. We keep seeing first-time homelessness. We keep seeing inflow into homelessness. And then what happens is the general public looks at that and says, you've been doing all this stuff, funding shelters and funding housing, and we still have homelessness. It must not be working, which would be kind of like saying the emergency room keeps spending all this money on heart attacks and gunshot wounds and car wrecks, and yet we still keep having car wrecks. The emergency room isn't designed to prevent depression or treat diabetes before it's in crisis. It's designed to deal with the emergency. So the thinking is now we need to really begin moving upstream and saying, how could we create essentially a primary care system for the homelessness sector to keep people stabilized in housing, to keep people from losing their homes in the first place, because it's healthier, it's cheaper, it's just more logical to do it that way. And so that's where a lot of our energy is going these days, because that system has not been built. We're putting a lot of emphasis on prevention right now.
And what are some of the strategies that seem to work in that area?
There are a number of really cool things that are emerging around the country. One of those is efforts to provide direct cash transfers to people. And we've seen young people, for example, youth aging out of foster care, who, if we can just stabilize them with a little bit of income, and this is often $10,000 a year or something. It's not nothing, but it's not as much as it costs to provide shelter and outreach and case management. If we can do that, young people stay housed. They actually do well. They can get back to school. They can get jobs. They can connect with friends and family. We've seen those kinds of pilot efforts working very well with young mothers, also with young families, with kids 0 to 5. There's a great pilot in Birmingham, Alabama, focusing on stabilizing families at that critical moment of the birth of a young child to make sure that they don't slip over the edge into homelessness. So I think there are some really good, exciting practices just around income stability. I mentioned Santa Clara, California earlier. They've done some excellent work around flexible funding pools that can be used to pay back rent and pay for a car repair and pay for utilities that are about to be shut off, to just provide a little bit of support for people to get through a tough time so that they don't become homeless. And what the research on that initiative has found is a immense cost savings. So first of all, people aren't becoming homeless, but it's also saving the system money by doing that, by investing early and making sure people don't get into crisis in the first place.
A lot of these examples do point to that truth that if something happens that was unexpected, that throws your family into crisis. For those of us who have a little more cushion, the crisis you still have to handle, but everything else doesn't get disrupted when you have that moment.
That's exactly right. And I think there's a component of structural racism to that observation as well. And that's that communities of color have not had the opportunity to build generational wealth through home ownership and through investments in the stock market and other things in the way that white families have for generations now. And so what we see is that it just doesn't take much. It might be a $300 car repair that somebody can't afford, and therefore they lose their job, and therefore they have their electricity and water shut off, and then they become homeless. And if you'd only had that $300 at that critical moment, it doesn't solve everything, but you can really stave off a crisis. And you mentioned the California statewide study on homelessness that Dr. Cashel and her team conducted, and it found exactly that people were saying, if I had only had a little bit of money at the right time, or a little bit of money over some months to get me through a period of difficulty, then I wouldn't have become homeless. And so I think taking those lessons and crafting policy and funding around those kind of early interventions is a really critical next step for us.
One of the other legs of your three-legged stool for your strategy is housing and supports, and a model that has spread, but not as much as it should, is housing first. And personally, I'm very touched by this. My son worked as a case manager in a housing first organization in Seattle. And I'd love to have you talk about the model and how does this operate within the broader landscape of some of the issues you're working on?
The basic idea of housing first is that if you want to help people exit homelessness, get them into housing. Right? That's the first fundamental step. Seems radical, I know.
A little obvious.
The idea is housing first does not mean housing only. It doesn't mean you just stick somebody in an apartment and cross your fingers and hope it goes well. It means you get people into a place and then provide really good access to mental health care, to substance use treatment, to addressing their medical conditions, to connecting with employment services or other supports. And the idea is that those two things are offered, housing and wraparound supports, but the services are not required to stay in housing. Just like anybody else who's in housing may want to access various supports, a primary care doctor or a therapist or others, but you don't lose your housing if you don't go see your doctor. You don't lose your housing if you're not doing a great job taking your medications. Most of us who are not in programs are allowed to drink in our homes if we choose to. There's a lot more autonomy and kind of dignity to having that personal choice about how you live your life. Now, the result is that you get really good outcomes when you put people into housing and provide wraparound supports. Now, some people are still using drugs or alcohol. Some people are still wrestling with their mental health conditions. But the foundation, the stability that housing provides is much more effective for dealing with those conditions than living in a shelter or a tent or sleeping on a bench, where it's impossible to deal with psychosis or depression or trauma or addiction if you have no idea where you're going to sleep tonight. And so the idea is get people housed, provide really good supports, and the outcomes are fabulous. The outcomes are 85, 90% housing retention rates. It doesn't work perfectly for everybody. We know that, but it was transformative when Housing First came along 20 years ago. I want to address one of the critiques of Housing First, and that is that it doesn't solve homelessness. I believe that it actually solves homelessness at the individual level quite well, but it's not designed to prevent homelessness from happening in the first place. And so what people see sometimes is, okay, you've invested all this money in Housing First, and yet we still see homelessness. And they'll say it must not be working. It must be a failed policy, which I think is really just bad analysis. I don't think that's true. I think it has worked very well for the people who are in those programs. One issue is that there's not enough of it. Another is that we've not paired that with a good prevention strategy. And so we keep seeing new homelessness, and we've had a hard time funding Housing First at a level to keep up with the demand. The last thing I'll say on this, Claudia, is that the proof point on Housing First is how we as a nation have addressed veteran homelessness. And we've done that in a bipartisan way over more than a decade, with HUD providing the housing and VA providing the wraparound supports, and it works.
It's great to use the analogies of broader healthcare, because I don't think we would say that a hypertensive is going to solve all problems with health, right? We understand that this is a complex issue. And I think that similar nuanced, layered approach where you have prevention, you have crisis, you have basic supports is such an important one. I want to start with something that you have said, which is that homelessness is a public health crisis. And I just would love to have you explicate that a little bit.
But when I think of homelessness as a public health crisis, it's that this is a healthcare issue. Housing is healthcare, and we can use the terms of social determinants and all of the kind of fancy words that we all use. But this is really about taking care of people's health and well-being. And the best way to do that is a stable home, a door you can lock, a bathroom of your own, a kitchen to cook in, a stable place to be where you can be safe and secure and connected. And so I think we have to address it in the same way that we would address a pandemic or any other public health crisis.
We are seeing a really substantial trend that is matched with a federal government push for Medicaid programs across the country to start offering more social services as a complement to medical services. More than 20 states now have what we call waivers, either approved or in process, that would bring this about. And what's really interesting is it's red and blue states, it's rural and urban states. And a lot of the services that are being offered are related to housing, everything from asthma remediation, which would be making the home safer for children, especially, to helping people with their housing deposits, to housing navigation services, to tenancy services, support for folks that are leaving either jail or leaving the hospitals. So generally what that's meaning is that either the Medicaid providers or the Medicaid managed care plans are now entering into these relationships with a whole team of people in local areas that they've not really paid a lot of attention to. Both the direct service providers, but also the policymakers at the local level, the mayors you were talking about who are trying to address this. What advice would you give those Medicaid leaders who were designing and implementing these programs at a state level about how to go about this big transition?
The one piece of advice I would give is to be as creative as you can possibly be. I think Secretary Becerra at Health and Human Services and his team have done an extraordinary job of pushing through waivers and flexibilities and really creative thinking about how Medicaid dollars can support a whole range of the full well-roundedness of a human being and everything that they're facing, recognizing that housing is healthcare, recognizing that the air we breathe really does have a long-term impact on the health of children and older people and all of us. Um, as of February, 3 or 4 months ago, there were 4 states, Arizona, New York, Oregon, and Washington, that have approved covering rent and temporary housing and utilities for up to 6 months for people with Medicaid waivers. And that's, I think, a real signal of creativity on the parts of those governors and their teams. 3 other states, California, New York, and Washington, have approved covering recuperative care up to 90 days and short-term post-hospitalization housing. So I think all of those kinds of interventions work to either help people not become homeless or to stay, if they're already housed, to stay stable where they are. So I think there's a real appetite on the part of federal leadership at this point to continue being creative with how we use these Medicaid dollars.
I think it was Oregon just approved specific supports around heat and climate. So that might look like air conditioning or other kinds of things to help stay safe within a home, especially in conditions where there's a lot more high heat days than before.
Absolutely. I was just in Phoenix with our team recently and meeting with Mayor Gallego there and meeting with a number of homeless service providers. Last year in Phoenix and in Maricopa County, they had 645 heat-related deaths, the most on record, and about 45% of those were people experiencing homelessness. I was speaking with Mayor Giles in Mesa, just next door. They're really trying to set up cooling centers and work on more creative solutions. Again, back to your question of homelessness being a public health crisis, this intersection with heat-related deaths, with, if you're in the Northeast or the Midwest, with cold-related deaths, homelessness can be deadly for people. And the solution is to get people safely inside as quickly as possible. And so I think the creativity that we're seeing from communities around addressing the impact of climate change is also another really important area.
Recently, I think it was in May, your agency released a new guidance document that is meant for the use of health systems that are wanting to provide more equitable and more effective care to people that are either homeless or at risk of homelessness. And I'd just love to have you talk a little bit about what prompted this and what are some of the key takeaways folks should have in mind about this guidance.
What prompted this was exactly what you and I were talking about a few minutes ago, that homelessness is a public health crisis, and hospitals and health systems have a real role to play in addressing homelessness. And we're increasingly seeing health systems bring their resources, their staffing power, their creativity, their role as leaders in the community, bringing all of that to bear on local homelessness responses. And so partly we wanted to capture the good stuff that's happening and hold it up, but also challenge health systems that aren't necessarily hands-on in their community's homelessness response to get in there, to be part of the solution. And the guidance lays out a number of areas, things like delivering care outside of traditional medical facilities. We see this with street medicine teams and really good healthcare for the homeless outreach, but also hospital-based teams that are going out into the community, partnering with non-health organizations. I think there's often been a kind of chasm between the housing world and the healthcare world. We're hoping that will begin to get more bridged. Looking at data sharing across all of these systems, where healthcare has so much data on people and how they move through systems of care, can we begin tying that to other systems like child welfare, like the homelessness system, like the criminal legal system. The guidance talks about promoting supportive and affordable housing. We do see health systems actually directly investing in affordable housing. Groups like Kaiser Permanente out where you are, and United Healthcare, and others that have literally invested dollars into making sure people are housed. And then looking at things like health equity and some of the racial disproportionalities we see in homelessness, and engaging health systems in more upstream prevention, screening for homelessness risk, that kind of thing. So our hope is that this guidance spurs conversation, spurs activity, spurs an additional set of partnerships that might not be in place right now.
I really appreciate the way when we talk about creating more equity and addressing the extraordinary racial gaps in the risk of homelessness across the country, that you've taken it back to our history and the history of displacement of the original peoples by the colonists who came into this country, the slavery that displaced people, and that this kind of theme of displacement and removing people from access to the basic supports they need for a healthy life are very deep in our history. We haven't erased them, both because those original inequities persist today, but also because we have still had policies that perpetuate that over time. How would you invite people to think about that deep historical context for this work? And what are ways in which we can go about recognizing that and addressing it in a more effective manner?
I think it's critical to engage in curious exploration of where we're coming from, and understanding that knowledge of our past can help us craft a better future. That requires courage. It requires hard conversations across racial identity and across all sorts of other dimensions of who we are as people. But if we close our eyes to it, if we just pretend like everything's okay now, that racism was a thing of the past, or that those policies of Indian removal from their native homelands to reservations in Oklahoma through the Trail of Tears, or that the impact of slavery doesn't still have an ongoing impact on Black communities, that the more recent policies of school segregation and redlining, and all of those mass incarceration of communities of color, if we close our eyes to that and just like stick our fingers in our ear and say la 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 and pretend like everything's okay now, we're going to keep getting the same bad outcomes. We're going to keep perpetuating the impact of those racist policies. And so it hurts my heart to hear people say, let's just get over it. We live in a post-racial society. I sure wish we did. I wish all the outcomes were the same and that people had equal opportunity in this country, regardless of their sexual orientation or gender identity or racial background. But I think there's still a whole lot of discrimination. I think there's long-term impact of the old policies, and there's ongoing impact of how people treat each other. And that's true in housing, it's true in education and employment, it's true in healthcare. And so it requires an ongoing commitment to justice across party lines, across politics. It has to do with who we want to be as a society. And if we really want to be a society where everybody is treated the same, then we got to keep working at it. It's not going to get there by accident. It's not going to get there by pretending that racism is a thing of the past.
And you've mentioned something that reminds me of a conversation I had with Tony Iton on this podcast, where he was talking about narratives of opportunity and narratives of exclusion. And I think what you're talking about is how do we stay committed to and come back to the narratives of opportunity. But you've also mentioned in previous conversations that there seems to be an emerging narrative of blame and of political pushback on some of the models like Housing First that work well. But as a leader wanting us to return to the narrative of opportunity, What do you see as some of the strategies we can use to pull ourselves back to where we need to focus?
It's a really hard question. And I honestly don't know the answer right now. I think it has to start with me. It has to start with you. It has to start with our individual conversations and circles and how we engage people who believe differently than we do. And this is true whether you're a progressive or conservative or anywhere in between. Finding ways to talk with people across difference, and acknowledging those differences, but still trying to find common ground where we can. I would also like to see a lot more just individual kindness and respect towards one another, and not so much hatred and vitriol and finger pointing, and where everybody. It's not just like we see people as a political opponent or something. We see people as less than human. We see people as deliberately trying to ruin the country or something. And so I think there's an individual practice for me, of cultivating hope, of recommitting myself to hope every day, of cultivating a belief in the goodness of people, even when they're not necessarily behaving at their best, including myself. And so I think there's a part of this that has to do with how we choose to carry ourselves as individuals, and then bringing that into our jobs and our professional roles and our roles in our communities and in the nation, using the platform that you have to be a positive force for change. And that's true whether you're a nurse in an emergency room or a street outreach worker in an encampment, or an elected official in the halls of power. How are you going to use the position you have, the power you have, to make this country and make this world a better place?
Thank you. And as the final question, I always say this is the free advice part of the conversation. I recently joined the Berkeley School of Public Health as the Chief Social Impact Officer. And it's such an exciting opportunity to ask these questions about how can these powerful, resource-rich organizations, the universities, public universities, have a more bigger and more effective and bolder role in crafting the world we want to see. And so in public health, it's all the things we've been talking about. So I'd love to have your advice about what might be some focus areas, what might be some strategies. And I know you have a background as well in social innovation that you'd recommend we think about.
I think what I'd like to do, Claudia, is bring it down to homelessness, because that's my kind of area of focus in my work and in my vocation. Teach young people about homelessness, get them engaged in the community, get them involved in service and in internships and volunteering, and run courses on the intersection of structural racism and homelessness, run courses that include best practices around helping end homelessness. I think beyond that, as institutions, universities in particular have a lot to bring to the table around homelessness, around whether that's a legal strategy for combating laws that criminalize homelessness, or whether it's around creating a more public health oriented response to homelessness. We need the brain power, we need the creativity, we need the partnership of universities right in there with the nonprofits and with the faith community and with the business community and with the electeds. Make a decision to get involved with this issue, because it is one of the most critical issues facing our society.
Well, listen, it's been such a pleasure to have this conversation. And I have so much reading to do coming out of the strategies, what's working, the history. And so I'm so grateful for you and look forward to sharing this conversation with our audience.
Thank you so much.
As I mentioned at the top, about 3 weeks after Jeff and I had this conversation, the U.S. Supreme Court gave cities a free pass to criminalize the act of sleeping in a public place. Cities can now arrest homeless people and clear encampments. An article I read in The Atlantic summed up in one line the bitter irony of this decision. Quote, "Communities turn to police instead of fixing their housing shortage," unquote. We don't need more policing of homeless people. We don't need more tools to clear humans off streets. We need more affordable housing. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Jeff Olivet and his work to end homelessness. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. We will be back in September with more episodes of The Other 80. Thank you for listening and have a great summer. Until next time, I'm Claudia Williams.